All right, everybody, good morning. Come on in and sit down and we'll get started. So my name is Stephen Little. It's my pleasure to introduce Jonathan Lindner this morning. Jonathan's currently the professor of medicine at Knight Cardiovascular Institute in Portland, Oregon. He holds the M. Lowell Edwards, as in Edwards valve, professorship in cardiology, and serves as the chief of the Division of Cardiometabolic Research at the Oregon National Primate Research Center. And we're going to hear a bit about that today. He's got medical degree and residency training in medicine from UT Southwestern, and then did his cardiology training at UVA, and he's been in Portland now for about 11 years. So his expertise is in the fields of cardiovascular imaging in general, microvascular physiology. He's the PI on several NIH R01 grants exploring this area. He's got a research lab, sort of pioneered a lot of work in contrast ultrasound, and we'll hear about that today. Jonathan is the president-elect for the American Society of Echo, so he'll take over that role in June. He has been on he's vice chair of the exam writing committee for the National Board of Echocardiography. So I know the fellows are very interested in that. They'll have the opportunity to meet with Jonathan around lunchtime and ask those tough physics questions you keep asking us. Direct them all right there. He writes them, so he'll help you answer them. And Jonathan is also on multiple committees and boards for the NIH, the ASC, the ACC, the AHA, and the NBE. So without further ado, please join me in welcoming Jonathan to talk to us today.
Thanks, Steve. The only thing missing from that introduction was getting the dandruff wiped off of my shoulder. If you don't know that reference, you haven't been watching CNN in the last 24, 48 hours. So thanks. It's a great pleasure to be here. Love this institution. Love the stuff that comes out of this institution, and I'm looking forward to giving the talk. This is a great backdrop, by the way, with the space theme, and that's essentially how I'm starting my talk today. Reason why I'm talking about space to begin with is it really sets the theme for what we're going to be talking about. So I'm in Houston. You got NASA around the corner. I actually just finished up with a 2.5-year grant from NASA. We were trying to figure out how to screen astronauts for susceptibility to space radiation using imaging and omics and things like that. But I start with this Hubble telescope, which is up here about 350 miles up in low Earth orbit. And the reason is that once you're out of the Earth's atmosphere, you can make really clear, pretty pictures, really nice pictures. So this is an example of one of the pictures that it took, which was of a twin quasar system. And the reason why I actually show you this image is the fact that this is actually not a twin quasar system. So once you had the Hubble telescope up there and you had really pure information coming back, they could do a spectroscopic analysis of this and figure out this was one quasar. And this other thing that you see right over through here is actually a galaxy intervened between the quasar. So what this is this is essentially gravitational lensing. This is essentially light coming from this quasar that gets bent and projected into two different images. And the reason why this is important is this is probably the best example of Einstein's theory of relativity. So the theme that I'm trying to set with you here is that when you can make really nice, pretty pictures with a lot of clarity, it's not just pretty, it actually gives you unique information. And that's what we're going to be talking about today, which is unique information from neat pictures. So cardiovascular imaging has advanced tremendously over the last couple of decades. We've got lots of techniques now that can give you non-invasively really pure and lovely structure of the heart, new ways of looking at function of the heart, such as with strain imaging that you saw there. Even new methods for looking at myocardial metabolism and perfusion, some of which you could actually even call molecular imaging with some of the probes. What we're going to be talking about is something a little bit more detailed in terms of molecular imaging, which is specifically looking at one molecular process with imaging and how we do it in certain cells, certain processes, and that alone, and why we want to do this. And I'll start with this slide. And this is, I start with a radionuclide, a PET CT imaging of cancer. And the reason why I start with this slide for molecular imaging is really the leaders in this, in terms of clinical application of molecular imaging, cancer docs. Okay? It's really been integrated already into the selection of chemotherapeutic agents, and it's with radionuclide imaging. These are the people who are really pushing the envelope and at the apex of this. This is just one example of a tracer. And I show you this one. This was developed by Sean Chen. This is a dimeric RGD that's tagged to a fluorine, an F18 for PET imaging here. And the reason why is they're detecting cancer in this person before there's even really a significant growth. You can actually see something up through, oops, need to get rid of that hyperlink, sorry. You can actually see the tumor in through there, but you're not actually imaging the tumor. You're imaging the normal tissue around the tumor where the angiogenesis is starting to occur. So essentially, you're using this RGD peptide to look at the angiogenic process, not the tumor, but actually looking at what the tumor is doing to its environment so that you can actually detect it at an extremely early and curable stage. So in cardiovascular medicine, there's lots of things that we may want to go after with molecular imaging. This is a partial list. We're going to touch on a lot of these things, but key thing for you to know from this slide is not just what we're going after with molecular imaging, but the fact that we have really a menu of different potential targets that can give us information on things such as atherosclerosis or regenerative medicine or arrhythmogenesis. First, let's talk about how we actually do molecular imaging. So this is a word slide. Just about all my slides are going to be pictures. Yay, I'm an imager, lots of pictures, so hopefully you'll be excited. But I got a couple of word slides to go through first. This is one of them. This is how we do molecular imaging. The most common is number one there. And I'll just, instead of using those words up there, number one is essentially you take a contrast agent, you do something to it so it becomes smart and sticks to an area of disease. The second one is essentially cellular retention from some sort of a natural process. And a good way of describing that is something like, like FDG. FDG is essentially F18 FDG is glucose. So it gets taken up by the metabolic machinery and retained in a cell. So that's an example of molecular imaging using endogenous machinery. And then there's other things like endogenous tracer activation. Certain fluorophores, when you put them together, they essentially make each other dim. And only when they're acted upon by a protease and they split apart do they become essentially bright and give you a signal. So that's something, a way of essentially imaging a protease activity. And the last one is just endogenous signal enhancement. A good example of that is bold imaging on MRI, where you can actually detect oxygen levels in tissue. I'm going to be mostly talking about number one, because that is really where a lot of the really interesting work is going on right now. And I'll just give you an example of what this looks like. So back in the 90s, I was very much involved in the creation of ultrasound microbubble agents. These are contrast agents that essentially ring in an acoustic field. And anybody who's spent some time in the echo lab here knows that we use these things not just for left ventricular opacification, but for tissue perfusion. And the reason why we use these things for tissue perfusion is right here. Here what I've done is I've fluorescently labeled microbubbles, and you see how they're behaving through the microcirculation. This is a branching arteriole, here's a capillary bed, and here's a venule in through here. And these things ring in a given acoustic signal, but they behave just like red cells in the microcirculation. They don't lodge, they don't stick, they just pass through freely. Very pure perfusion tracers. And because of that, looking down here, this is actually a mouse leg in kind of long axis. And what I've done here is I've destroyed all the bubbles with ultrasound, and then you see them coming back in. You get this little microvascular angiogram, and then you get the tissue perfusion, which takes over. So this is how these things usually work. So they pass through the microcirculation unimpeded. When you want to make a contrast agent targeted, you got to do something to change this behavior. You have to make it stick to an area of disease. And this is essentially what we do, for example, with contrast ultrasound. And I just use this as an example because it's easy to see. We take our lipid microbubbles, and instead of having them pass through freely, we put some sort of ligand on the surface of them. And generally, for my 2-micron diameter particles, I can put about 50 to 70,000 ligands on the surface of these things. And then they no longer pass through freely. Instead, they will actually stick to areas of disease. And this is just an example of some fluorescent microbubbles that are adherent onto the surface of this inflamed venule. You know it's inflamed because you see these leukocytes that are rolling on the endothelial cell surface. These bubbles are targeted to something which we'll discuss in a little bit. So keep this in mind. I'll discuss what this is in about 5 slides or so. But this is essentially bubbles that are targeted to inflammation so that we can inject these things in, wait a couple of minutes, and then just image the tracer that's not passing through, but is just stuck and left behind. So why do we want to do this? I get asked, I put this slide in defensively because I get actually asked this a lot in the Q&A session, which is, why do you need to do that? Why do you need to do molecular imaging if you've got omics? Doesn't omics explain everything? Genomics and epigenomics and proteomics and metabolomics. And indeed, omics, and I've had grants on omics, it gives you a tremendous amount of insight on disease processes. But I'll hold for you that if you don't have tissue changes, either in terms of structure or function, you don't have disease. And if you don't reverse those abnormal structures or functions, you don't have therapy. So you can do whatever you want to omics, unless you actually have something wrong with your tissue and you have something to reverse it, you really don't have disease or therapy. And that's why we're developing these techniques. So this is kind of the take-home slide. If you're going to remember anything, remember kind of this slide, which is the raison d'etre. This is the reason why we are doing molecular imaging. And it's really in 3 different categories. Number 1, it's to be used, hopefully, in clinical medicine. It's just now starting to be used in clinical medicine. And we want to use it for really early diagnosis of disease, to be able to diagnose disease at a more treatable stage, for example, evaluating response to therapy, or this whole thing that the NIH loves, which is customized therapy, personalized medicine, essentially giving a drug based on not just the fact that somebody has a disease, but their type of disease, their flavor of disease. It's also being used, and we'll talk a little bit about this as well, in science. It's being used, molecular imaging is being used to uncover new druggable pathophysiology and for use in preclinical models for testing these new drugs. So a lot of use on these, and we'll discuss some of this as we go along. Now, one of the things is there is every form of imaging that we use non-invasively in cardiology, MR, nuclear, echo, CT, even in preclinical things like optical imaging. Every single one of these has ways of doing molecular imaging. They all have contrast agents, and for all of them, there's a way of actually doing molecular imaging. So how do you choose? When do you choose one versus another? Well, it's based on the things that are on this slide, and they can range from kind of highfalutin, really deep thinking issues to practical issues. So for example, sensitivity and specificity, okay? If you really need to detect something in a very early stage, you may need sensitivity, or you may need really good spatial resolution. So that's the performance issues. Practicality, how costly is it? So here's just a good example. If I develop a molecular imaging technique for screening patients for very early aggressive atherosclerosis, I don't want that thing to cost $2,000 and to take a day to do, okay? It has to be something that's quick, cheap, and easy. So that's the practical side of things. And then feasibility, okay? A great way of kind of thinking about feasibility is think about contrast agents. Some contrast agents, like the one I just showed you, the ultrasound contrast agents, they stay within the vascular space. They don't leave. So I can't go out and find a tumor cell with them. So if I want to do molecular imaging of a tumor cell, or let's say a plaque macrophage, I got to use a diffusible tracer, something that's going to get out there into the tissue. So it has to be a small molecule. That usually means nuclear imaging. So let's talk about some of the uses of molecular imaging and how we're going to hopefully be using some of these technologies in the future in cardiovascular medicine and cardiovascular science. Let's start with the issue of how molecular imaging may give you more rapid and more confident diagnosis. And one of the areas that is kind of the low-hanging fruit is rapid diagnosis of myocardial ischemia. You guys know what I'm talking about. It's the patient who's in the ED, came in with chest pain. The chest pain was, let's say, 2 hours ago, or resolved in the ambulance after they got their nitro, morphine, GI cocktail, oxygen, aspirin, benzodiazepine, God knows what. And the question is whether or not somebody's chest pain was actually coming from myocardial ischemia. So there's a lot of interest in developing tracers for what's called ischemic memory. A tracer that you can essentially inject in and then image the heart and say, aha, this person has had ischemia sometime in the last 12 hours. And not just that they've had it, but is it a tiny area of ischemia or a big area of ischemia? So for risk stratification as well. And there are tracers that have been developed that are pretty far along with this. Not all of them are actually, some of them, like this one, are starting to die a slow death. This is BMIPP, which really got the furthest in this. So as most of you know, the heart's main energy source is fatty acids. Okay? So about 60% at rest of the metabolism of your heart is from long-chain fatty acids, and it undergoes oxidation. Well, when you become ischemic, you actually switch away from oxidative metabolism to glucose metabolism, okay, and to some degree lactate metabolism. And so this tracer is essentially a long-chain fatty acid with a radionuclide at the end of it. And essentially, if you are ischemic or you have had ischemia sometime in the last 12 to 18 hours, you've switched away from fatty acid metabolism to glucose metabolism. And so because of that, this tracer does not enter into myocytes, and it gives you kind of a blank area shown through here on a BMIPP scan. And this tracer actually got pretty far along. This was from this was a phase 2B trial. This was done by Mike Kontos, led this trial. And this was a bunch of folks who came into the ED and received BMIPP imaging. These are people with low to medium pretest probability of disease. And this is its performance on an ROC. curve. So you can see that it performed well, but not great. You kind of want this to have a little bit of a bigger area under the curve of the receiver operating curve. This is the sensitivity, and I put actually the negative predictive value, because really in the ED, when you have somebody come in with chest pain, one of the biggest things is if you've got a way of detecting ischemia, the most important thing is negative predictive value. You don't want to send people out of the ED who actually have ischemia. Okay? So here's how the BMIPP did, and you can see that it did okay, but not great. So the bottom line is this tracer probably is not going. I haven't seen any activity. I was actually one of the blinded readers in one of these trials, and I can tell you one thing, which is it is the hardest. If you think that is John Mamarian here? No? Okay, good. If you think that SPECT is hard to read and it's a bunch of kind of fuzzy reads, this was even harder. This was much harder. Good. Nobody tell John that I said that. So I don't think that this tracer is going anywhere. Not only that, but you really don't want to take somebody who's in the ED with chest pain and ship them off to the nuclear lab for an hour or an hour and a half and give them a bunch of radionuclides and have to wait about 2 hours to get your answer. Because of that, this is actually something that we're going to be entering into clinical trials with this year. So this is using our contrast ultrasound agents. And the advantage is it's bedside and it takes 5 minutes to do. And essentially what we've done is we've taken some of those microbubble agents that you've seen and we've studied them with ligands, the same ligands. The one that we're actually very interested in is we've taken the same ligand that's on leukocytes that make them stick to the endothelium and roll along the endothelial cell surface. This is essentially a ligand against P-selectin. So whenever you have even very brief mild ischemia, it produces a very mild inflammatory response. And essentially that allows these leukocytes to say, hey, wait, what's going on here? So the endothelium in this venule is expressing P-selectin. PSGO1 on the leukocytes goes and finds it's constitutively expressed. And these things roll along the endothelial cell surface. Well, if I put the same thing on these microbubbles, that's what that image that I showed you earlier is, which is these contrast agents which are stuck to the same thing that these leukocytes are rolling on. So that allows us to actually do imaging of recent ischemia using contrast ultrasound. We just inject the tracer in, it sticks, and we image. Now these are actually, this is kind of the chance favors the prepared mind kind of a thing. These are actually images not from our P-selectin agent, but actually this PS agent, which is, we've made it much more simple. We've just put phosphatidylserine in the shell of our bubbles. Anybody know what phosphatidylserine is or does? You know it is. So essentially when a cell dies, there's phosphatidylserine in all of our cell membranes. When a cell dies, all the phosphatidylserine, which is kept on the inner leaflet of the membrane, pops out. And it's a way for saying, I'm dying, I'm on my way out, come clear me out. So it's a clearance signal. And so it's actually a way of making our bubbles kind of saying, hey, I'm kind of dying, clear me out, come get me inflammatory cells. And because of that, we can actually use these things to diagnose ischemia all the way out to 6 and even out to 18 hours after ischemia has resolved. And we're not talking about infarction, we're actually talking about just ischemia. And you can see how you inject these things in and it really just mimics the whole risk area of where there's been recent ischemia. So we're starting these clinical trials and hopefully this will work because this will really increase workflow in the ED. So that's an example of rapid diagnosis and better confidence in your diagnosis. I put this slide up here, which is whenever you come up with something like the agents that I just showed you, which are targeted against inflammation, there's always cross-fertilization. So inflammation is such an important process in so many disease states that once you develop a tracer against one thing, somebody's going to grab it and use it for something else, these kind of orphan applications, if you will. And that's exactly what's happened with some of these tracers that were originally targeted against ischemia. And this is just an example. This was actually from a former fellow of mine who's back in Switzerland. And he's actually taken some of the bubbles that we've developed, either those phosphatidylserine bubbles in blue, bubbles that are targeted against P-selectin in red, or ones that are targeted against CD4 cells in green, and use them to be able to diagnose myocarditis in a mouse model of acute myocarditis. So a good way of essentially doing a bedside diagnosis of acute myocarditis, or transplant rejection, or XYZ. Let's talk a little bit about early diagnosis. Okay? And by early diagnosis, I don't mean rapid like myocardial ischemia. I'm talking about diagnosing disease at a really early, more curable stage. A good example of that is transplant rejection. Love to be able to diagnose that at a very early stage, right? Well, I will hold for you, if you believe animal models of disease, that atherosclerosis is a curable disease if you catch it early enough and you give a drug that can actually cure atherosclerosis. So we got a bunch of cardiologists in the room. Raise your hand if you have ever cured atherosclerosis. Nah, nobody's. Even when you do a heart transplant, you can come close, but that doesn't even last for very long, does it? So we do all kinds of things. We bypass it, we stent it, we smush it, we do all kinds of things. We're whether you like it or not, guys, we're palliative doctors, right? We are the ultimate in palliative medicine, folks. And it's because we essentially can't cure atherosclerosis. Well, it turns out that if you believe animal models of disease, all the way up to non-human primate models, you can actually cure it if you can diagnose really aggressive disease in an early stage. There is a problem with that. And the problem is a lot of the drugs, and I'll show you some of the drugs that are on the cusp, the drugs that actually are needed to treat and knock down atherosclerosis in an early stage are going to be expensive. They have many more toxicities than statins, and you got to take them for decades, right? You're going to essentially have to take them for decades for them to work. Yeah, if you say, hey, listen, I can cure atherosclerosis at the very early stage over here on the left side of the screen, then essentially you have to kind of take it for a long period of time. And so you have to be able to select the right patients. You have to be able to say, aha, you, 22-year-old, you're going to have MIs and strokes in your 50s or 60s, and I can prevent that. But it's not going to be like a widespread use of an expensive and potentially toxic medication. Most people who have been doing molecular imaging in atherosclerosis have been really focused on the late stage stuff, looking for hot plaque, vulnerable plaque imaging, you've probably heard it called. Okay? And there are many different probes. So one of the reasons I show you this is to let you know that there's many different targets in atherosclerosis, and you have to pick the right target depending on what you're trying to accomplish. So if you want to actually look at a hot plaque, you have to go looking for things that happen in late stage disease over here. If you really want to know early predisposition for atherosclerosis, you don't have as many targets. And what you got to go after are things such as oxidized LDL entry into a plaque or endothelial cell activation. Okay, those are really the two best targets. So what do we have? How are we doing this? Well, the thing that a lot of people are using in some clinical trials right now is FDG PET. So where does FDG PET come from? Well, it mostly comes from the cancer literature. So this is, essentially a PET tracer that's hooked up to glucose. So it's essentially putting fluorine into a glucose molecule. And cancers are hypermetabolic, and so they're also somewhat anaerobics, and so they don't use a lot of lipid for their metabolism. They use glucose. And so this is an example of a PET scan from a patient with breast cancer. You can actually see the primary in the breast there, and then the axillary and cervical nodes with the hot activity. Well, that's essentially inflammation, hypermetabolism. And atherosclerosis in an advanced stage with a lot of inflamed plaque is hypermetabolic as well. And to some degree, it's also anaerobic. And so there's a lot of anaerobic metabolism, and that means glucose. And these are just some examples. You can find this all over the literature of essentially FDG uptake in the aorta in this person. It's a little bit harder for coronaries, and the reason why it's harder for coronaries is the myocardium is also taking up glucose, so it kind of hides the coronary arteries. So you kind of have to go looking at other vessels, such as the carotids and the aorta. But that's essentially FDG, and there's lots and lots of data on FDG. And I'm not going to spend a lot of time with it because it's a huge literature, and you can probably have Ahmed Tawakkol or Zahi Fayed who can come down and proselytize FDG PET all day long. And they do a good job of it, and they've got good justification. It's not a very targeted agent, though. This is just kind of a blunt instrument. But this is the type of data that they're getting from it, which is not bad, showing you that the relative risk here for patients who actually have a lot of activity, for example, in the aorta, have a greater likelihood for having major adverse cardiovascular events. So it really is kind of a good risk stratifier, and it actually adds on top of lipid profiles, and that's really kind of nice. Problem is for a routine screening tool, this is kind of a significant amount of radiation, and it's costly. It's really costly. So as a screening tool, not the greatest thing in the world. So what are we developing that could be used as screening tools, not just for hot plaque, but actually for this other idea that I told you, which is really early detection of really high-risk disease that people are going to get 2 decades down the line? Well, here's one of the things that people have developed, which is protease-targeted agents. So this is an example of an agent that was developed by Sam Simicus at UCSD. He was also part of we were talking last night, he was actually part of a company that they started about 15 years ago called ISIS. So, and they had their little bags that they carry around that said ISIS on them through the airport and things like that. So they very quickly changed their name to they changed their name to Daesh. No, they changed it to Ionis. So it's. But anyway, I digress. So this tracer it can be hooked up. This is a tracer that's targeted against MMPs, matrix metalloproteases. These are the proteases that are released by neutrophils. They degrade the collagen. They create an unstable plaque. And you can use this to do, in this mouse model, this ApoE knockout mouse, where you can see all of this protease activity on ex vivo zymography from the carotid. You can pick up the carotid through here. You can put it with an MRI tracer. You can actually put actually, no, this is not, I take it back. This is not SAMS. The SAMS is on the next slide. This is actually something from the old Bristol-Myers Squibb medical imaging group. But this is a probe that is targeted to proteases, so you can actually look at protease activity in a plaque and say, a lot of stuff going on in that plaque. That's still not a great way of really looking at the early plaque, though. And here's Sam's work, which is looking at oxidized LDL. So he actually has developed a bunch of ligands that will actually go find oxidized LDL and will accumulate, as you see through here, in areas of atherosclerotic plaque in an ApoE knockout mouse model, in a Watanabe rabbit model. This is back in an ApoE knockout mouse model with the same probe. Rather than being nuclear, it's hooked up to an MRI contrast agent. This is the carotid artery from the mouse. And here you can see, after injecting in this tracer, you can see all this contrast enhancement because there's oxidized LDL starting to go. And you can see that there's no major plaque here. It's just the starting stage. So this is a great approach. I love this approach. The only problem with this approach is this that you see right up here at the top of the screen, 24 hours. So this is with a nanoparticle, an MRI nanoparticle, and the problem with MRI nanoparticles is they circulate for a long time. If you inject something in and you want to see it lighting something up, you've got to wait for the free stuff to clear out. And so, so this takes quite some time to actually get your images. So as a screening technique, a little bit problematic, but they're forging forward with it. This is what we've developed out of our laboratory, which is a contrast ultrasound way of doing it. So this is from a mouse model. This is a reproducible murine model of atherosclerosis. You don't need a high-fat diet. 10, 20, 40 weeks. At 10 weeks of age, you have almost nothing. You have monocytes entering the vessel wall. 20 weeks, you have fatty streaks. 40 weeks, you have big honkin' plaques, big, huge plaques. But you can see here, this is a mouse aorta. This is all the signal coming from our bubbles that are stuck to two adhesion molecules, P-selectin and VCAM. These are two of the key adhesion molecules on the endothelial surface that monocytes bind to get into a plaque to start the atherogenesis process. So this is essentially molecular imaging in blue here in the atherosclerotic versus the wild-type mice, showing you that you can actually detect atherogenesis, the beginnings of atherosclerosis, at an extremely early stage, right when fatty streaks are just starting to be developed in this mouse model of unstable accelerated disease. And so this is a great example of being able to detect disease at a very early stage with something by looking for the same thing that the monocytes are looking for in early atherosclerosis. And it's not just for mice. We're actually doing this in non-human primates. This is one of my rhesus macaques doing what he does best, which is eating. So you give them a high-fat diet, they'll eat it, they love it. You give them alcohol, about a third of them become alcoholic, they love it. If you want a rhesus macaque to go activity restricted, all you have to do is put a TV in front of their cage. And this is fascinating. They love The Wizard of Oz. We have yet to figure it out. We don't think, we've done studies and we've looked at them. It's not the flying monkeys. It's not the flying monkeys, but for some reason, that's like one of their favorites. But anyway, if I take a monkey and I give them a high-fat diet at the end of 2 years, so I actually did these studies every 4 months, at the end of 2 years, 2 years is what it takes to just get a little bit of an increase in IMT, intimal medial thickening on carotid ultrasound. And yet at a very early stage, 4 to 8 months, I can actually pick up. This is all the signal coming from, in this example, P-selectin targeted contrast agent, which is sticking, and we've got the same thing with VCAM. So we do have the possibility of potentially using these types of agents in patients to be able to detect disease at an early stage, but not just detect disease at an early stage, but actually use this to select for drug therapy at an early stage. And as long as we're talking about drug therapy, these same molecular things that we're developing, these targeted contrast agents, can be allies in the development of the drugs because they can essentially tell you whether or not you're having an effect with a drug. So here's what I mean. This is the process of drug delivery or drug development. It starts up here in the upper left, which is essentially drug development starts with a biologic target identification, figuring out a druggable process that you can develop a drug for, okay? Then it goes through all of these preclinical stages until you get to the status of needing to file an IND. You file an IND with the FDA, and then you do your clinical trials, and you file for an NDA, new drug application, okay? So this is the whole process, and it takes a long time, and it takes a lot of money. I'll give you a preview of the next slide. It takes 1.8 billion. The actual cost for a first in market, so first class drug, so a new class drug, out-of-pocket costs for a company is around 900 million. Capitalized costs 1.8 billion. So if you include capital, 1.8 billion for a new drug. Okay. So we believe that imaging can actually be used to grease the wheels, to essentially accelerate the process, either by finding new biologic processes or be able to be used in vivo imaging in animal models for dose ranging, on-target and off-target effects. Okay? This is a great way of being able to tell whether or not you're having the desired effect. But it can also be used in clinical trials to select the right patients to see whether or not the therapy works. Here's a good example that we use every day. We use an EF of less than 35% to select patients for ICDs, right? Because we know they're the people who are going to have VT and VF. So same thing, you can actually select based on molecular imaging patients who are more likely to respond to a therapy. And then usually when you do that, it gets incorporated into the clinical paradigms for using that agent. Okay? So that's where I have great hope for molecular imaging, which is we're not just doing this to amuse ourselves or to create new diagnostics, but we're using this in science to develop new drugs. And when you do that, it's probably going to be it's probably going to work its way into the clinical paradigm to be able to select the patients for those drugs. Okay? And here's some of the drugs in athero. This is a partial list. I couldn't fit all the things that I needed to on here. These are some strategies that people are using to either try to calm down advanced atherosclerotic disease or to try to essentially cure atherosclerosis at an extremely early stage. Okay? So given the paradigm that I just showed you, if I've got all of these drugs over here on the far left-hand side that have the possibility of essentially halting atherosclerosis at its inception and preventing it from going, you need a way to be able to detect these processes. And we can't do that with FDG, which is really used over here. And we can't do this necessarily even with calcium, CT-based calcium, which is kind of in the mid-stage through here. You have to get at it early. Okay? And this is where we're starting to use a lot of these molecular imaging tracers. Now that whole strategy hinges on the fact that eventually when we get into clinical trials with patients, can we actually use molecular imaging as a surrogate marker? So for the FDA, for cardiovascular new drugs, the FDA only allows 2 surrogate markers. Almost everything requires body counts, right? Outcomes. There's only 2 surrogate biomarkers in cardiovascular medicine that the FDA allows right now. Anybody know what those are? No? Cholesterol levels and blood pressure, exactly. Cholesterol and blood pressure, that's it. Those are the only 2 surrogate markers that the FDA allows to approve a drug without a body count, without an event rate. Cancer is not the case. So cancer actually has a completely different paradigm where they can actually use molecular imaging as a way of approving a drug. And this is why. So this is an example of a patient. This patient has a GIST tumor. So I know this is a cardiovascular audience, but again, cancer is leading the field in this molecular imaging. So this is an example of a patient with a bunch of metastatic tumors in their liver. This is pre-treatment. This is week 4 after getting imatinib, so Gleevec, one of the first tyrosine kinase inhibitors. Do you see any difference? I don't. Looks the same. Not until week 24 do you actually see a regression of the tumors. But look at this. At day 8, long before this week 4 scan, you can see all of this reduction in tumor activity. And because of that, the FDA has allowed FDG PET to be used as a marker for saying, I am going to approve you as a new chemotherapeutic agent. And if you got a good enough product like this for cardiovascular, you may be able to use this as the same paradigm. So people are starting to use molecular imaging and show that it can give you information on drug response. Now, we've started with the lowest hanging fruit on this, which is response to statins. This is an example, this is from a patient study. So this is actually a sub-study where patients were randomized to receive, these are patients with known atherosclerosis and risk. They either got a low dose or a high dose of atorvastatin. And what they did was they looked at PET FDG signal in the carotid artery after 4 or 12 weeks. And you can see here that there is a greater change, reduction in the plaque activity with FDG PET in those that receive high dose atorvastatin and low dose atorvastatin. Now, the question that I hold for you is, do you really need to use this expensive highfalutin technique if all you need to do is to look at cholesterol levels, which give you essentially the same information? But at least this is a start. This is the same thing with VCAM targeted imaging. So I showed you some of our data on VCAM imaging a plaque, like in the monkeys that I showed you. This is an example from Matthias Nerendorf of VCAM targeted imaging with a PET agent in the aorta. And this is in the aorta from some studies that we did, showing you that when you are statin treated, you can essentially knock down the VCAM signal. Same thing through here, showing you that you can use the statin not just to reduce hot plaque activity, which is a late stage event, but actually you can use it to knock down inflammatory endothelial cell adhesion molecule expression, which is a very early event, okay? So you can see we're starting to work towards using these tracers as a way of being able to assess drug therapy, even at a very early stage of atherosclerosis. And I put this slide, and this is the last slide that I'm going to show you in this kind of area, which is if they would have used FDG PET in something like the trials with dalcetrapib, they would have seen, dalcetrapib, this is essentially a failed trial in terms of reducing outcomes. They would have actually seen, this is placebo versus dalcetrapib activity. This is PET activity in the carotid arteries, showing you that it really did nothing. Okay, it really didn't reduce activity. Okay? And of course, the clinical trials were negative. Perhaps if they would have used this in a pilot trial, they may have had a greater level of suspicion that this drug was going to fail. Now, one of the other things that molecular imaging can give you is new druggable therapy. So you remember that paradigm I showed you of drug development? So one of the things, the very first thing that I showed you at the upper left was finding new druggable targets. Okay? So molecular imaging, if you have a way to be able to use these molecular imaging agents, you can actually find kind of new targets that you can go after. And I'll just give you a real quick story of this. So for years, people have thought that platelets interacting with the endothelial cell surface was something that actually triggered atherosclerosis, not just monocytes binding and entering in, but actually platelets. And why platelets? Platelets don't migrate. They don't go inside the plaque. This is immunohistochemistry of a plaque showing you platelets on the surface, and this is scanning EM showing you platelets on the surface. Well, platelets, even when they just bind to the surface, shed off a bunch of really bad actors, all of this stuff, okay? Cytokines, growth factors. They also, it turns out, if they layer down, they're a great landing site for monocytes. Monocytes will actually land on platelets much more avidly than they will on activated endothelial cells. But people didn't have a way of being able to tell whether or not platelets were adhering to the endothelial cells in vivo. Is this really going on? Because if you take a vessel out and you do immunohistochemistry like this, there's all kinds of artifacts that happen. You have to stop, the animal's dead, you fix them, and you can have platelets that just stick on. So it's a hard thing to do. So this is just an example, and this is a really quick story I'll go through because this is something I think that is very impactful that we've, I'm not a card-carrying vascular biologist. I like to pretend I am because I have some neat tools. But this is how we've contributed to vascular biology knowledge as an imager. So what we did was we took some of our contrast agents and we put an interesting ligand on the surface of them which will bind to activated platelets. So for those of you who are biologists here, that we put the active A1 domain of von Willebrand factor on the surface of these bubbles so that they'll stick to platelets. And this is, again, the aorta of a mouse, atherosclerotic mouse model. And in blue here is the signal coming from platelets, showing you that platelets are sticking here in the aorta even at the very early stage of early plaque development, fatty streak development, okay? Now, why are they sticking? Well, when I looked at the surface of these plaques in shear, under flow, I gave some fluorescent bubbles and I looked at them under flow and I saw these long strings, these long beads. Well, if you've got a bunch of, and these are essentially binding to platelets, essentially if you've got these long beads, that's a hallmark of von Willebrand factor multimerization. So VWF, as you know, is a big, huge multimeric protein. It's secreted by endothelial cells, and it sticks to endothelial cell surface, but it's usually cleaved off. It's cleaved off and says, no, 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 no. But if it doesn't go away and platelets stick to it, they form these long nets and strings and things like that. And that's exactly what we saw. And so what I did next is I took a bubble that was targeted against von Willebrand factor and looked for the signal and saw that as well. And when I looked at the microcirculation, I kind of found the same thing. So I took a bunch of atherosclerotic mice, and I fluorescently labeled platelets. This is what a normal microcirculation looks like in a mouse. Here's one of these atherosclerotic mice. And here what you're seeing is, I hate this little thing that comes up here. You can actually see in this lower left all of these fluorescent platelets that are essentially glomming onto the endothelial cell surface. In this picture over here, you actually see a monocyte, this little dark guy here, and you see all these platelets that are hanging out on the downstream end and binding to this monocyte, which is essentially VWF growing on the monocyte. So raise your hand here if you do critical care medicine, if you actually see patients in the ICU. So those of you who see patients in the ICU, you know what TTP is, right? Thrombotic thrombocytopenic purpura. It's essentially a disease people get when they're really ill, trauma, chemotherapy, sepsis. It's a horrible disease that has many manifestations, high mortality. It's essentially von Willebrand factor sticking on your endothelial cell surface, okay? And platelets stick to the von Willebrand factor, and essentially it's a consumptive coagulopathy. Your platelets drop and you get all these microthrombosis. That's essentially what this is. This is essentially this is from a review that we just wrote for Blood, which is this is the endothelial cells. We have these long strings of von Willebrand factor which recruit platelets, and those platelets essentially are a source for all these pro-inflammatory things. And the reason is this stuff is not being cleaved. It's the same thing as TTP, but it's happening at the plaque surface. So we've essentially defined a brand new pathophysiology, which is that early atherogenesis is not just an inflammatory disease, it's actually a mild form of TTP. And we were able to prove this by essentially this ADAM-TS13, which cleaves the von Willebrand factor. If we give that exogenously, this is the signal in black coming from platelets. In gray, the signal coming from von Willebrand factor in plaque. If we give exogenous ADAM-TS13, it all goes away in about an hour, okay? So once you have that, you have a druggable target. And so we've used very strong antioxidants. So the whole process of TTP is because of oxidative stress. And so we gave a very new, and this is a drug that we may be looking at for early atherogenesis. We gave a NOX2 inhibitor, an NADPH oxidase inhibitor, to show that we could essentially get rid, this is low dose, high dose, get rid of platelets, get rid of endothelial inflammation by stopping the process. So this is one little sidetrack of a story of using molecular imaging to define a new pathophysiology and then to use it to test a new drug to see if it worked. And I think that there's going to be a lot of this. We're going to be able to use molecular imaging in precision medicine. We use this all the time in cancer for precision medicine. I love this study. This is actually one of the best studies that I've seen on precision medicine using molecular imaging. So this is, on these two patients, this is a PET CT of metastatic breast cancer, showing you where the disease is. And then next to it is the complementary scan using zirconium PET tracer labeled on trastuzumab, a HER2 antagonist, okay? So this is a chemotherapeutic agent against HER2/neu. So not all patients actually, even if you're positive for the HER2, actually respond to this agent. And this shows you why, which is in patients who actually, some but not all of their tumors actually have the HER2/neu on their surface, they do not respond to drug nearly as well and have poorer outcomes on drug than those who had a lot of the receptor on their surface. That's what these Kaplan-Meier curves show. So this is a way of essentially using molecular imaging to say, aha, you're going to respond to that drug, so we're going to use it, okay? And there are possibilities of doing that. This is just this is essentially the only molecular imaging in cardiology that's approved right now, which is using adrenergic imaging with MIBG SPECT. So wherever you have high sympathetic activity, you actually have gaps in your MIBG SPECT. Now, because SCAR can do the same thing, you have to do perfusion imaging with SPECT together with it. So this is MIBG imaging where you see a hole here and a hole here. But this is a viable tissue. This is non-viable tissue. So this is an area of SCAR that has very high sympathetic activity. So people have used this based on the ADMIRE trial to actually select patients to receive ICD or not based on sympathetic activity, okay? So this is approved by the FDA. Who here uses this to select patients for ICDs? Do you guys use it? Nah, nobody uses this. And the reason is yeah, you can use it to select patients, but this is the patients who actually have high versus low sympathetic activity. So if you tell a patient, yeah, you're low risk, it's not no risk, it's low risk. And that's a problem. I'm not going to tell a patient, no, you don't need an ICD because you still may have a fatal arrhythmic event, but you are low risk. And I can tell you that in retro, and that doesn't work too well. So in this day and age, we're not using this really too much to select for ICD therapies. But we've got lots of other different ways of doing it. I'll just give you a sprinkling. This is using TSPO, which is an inflammatory marker, to be able to look at inflammation and where inflammation is happening. This is the TSPO agent showing you all of this high activity in an area of ischemia reperfusion injury, which essentially leads to infarct remodeling. So people are thinking about using inflammation imaging to select patients for new agents for preventing post-MI remodeling. I'll whiz through this data pretty quickly. But we're also thinking about this in ischemic heart disease for other things. So this is the CANTOS trial. You guys know about the CANTOS trial? So it was released at the ESC, and everybody was going, yay, this is like the greatest thing in atherosclerosis medicine that we've had in years. And this is essentially a trial where you take a bunch of people who've had MI and you put them on an IL-1 antagonist, IL-1 inhibition, okay, canakinumab. It was originally developed for rheumatologic disease. And here you can see this is placebo versus canakinumab. And yeah, you do actually have a reduction in recurrent ischemic events. So you have an MI, you put somebody on the IL-1 antagonist, and you can reduce all events, including in remote territories, by 17%. And everybody's going, yeah, it's like, wait. Look at the impact here. Expensive drug, very expensive drug, and you've got this kind of tiny little reduction in outcomes. Right? And we're excited about this? Well, I will hold for you that there may be a way of being able to select patients who are more likely to benefit from canakinumab. And the reason for it is this is mouse data that's from our lab. It's actually in press in JACC right now. This is a bunch of wild-type mice, and this is a bunch of atherosclerotic mice. BL is baseline. This is essentially using all this molecular imaging to look at inflammation and platelets on the endothelial cell surface. So animals that are atherosclerotic, as you see here, at baseline have much more signal. They've got atherosclerosis. But if you produce an MI in the heart, so you produce ischemia reperfusion of the heart, and then you go looking at the carotids and the aorta, remote territories, you can see that an MI creates this huge amount of increase in inflammation remotely in all of these other vessels. So we know that if you have a heart attack, your risk for having a stroke or a heart attack in a separate territory goes up sixfold for the next 6 months, 9 months. And we don't know why. Well, this is part of the reason why, which is your entire vasculature becomes inflamed. And once you see this, this may actually give you a way to be able to select patients who are more likely to benefit from things such as IL-1 beta antagonists, okay, or other therapies. I won't go into this. This is just showing you that you can knock down that signal. Finally, I'm going to finish up with using it for biodistribution and proof of concept studies. And actually, you know something, I'll whiz through this very quickly because I'd like to save some time for questions. But essentially, molecular imaging can be used for stem, and I put this, John's here, so I put this on purpose for John, which is we have ways to be able to use all these different forms of molecular imaging to load up stem cells to be able to track stem cells in their body because guess what? Stem cells, they ain't working so good. They're not working so good. So we have proangiogenic stem cells and we have stem cells that are being used for regenerative medicine. Great idea, but we've leaped into clinical trials. And I know this, I'm actually on the NIH Data Safety Monitoring Board for all cell therapy and gene therapy trials that are funded by the NIH. And using these stem cells for a 2% increase in LVEF is not what we're trying to do here, okay? So we gotta understand this process better. And part of it is being able to track where stem cells are and whether they're living, okay? And this is just an example of using, this is actually CXCR4 imaging for those of you who are biologists here to actually track where there is this proangiogenic chemokine which actually recruits stem cells in. So you can not only track where stem cells are, but actually look at the signals that are bringing stem cells into the heart. And I've got a lot more on stem cell imaging, but I'm gonna finish with this slide because this tells you essentially the whole story of using imaging as a tour de force to understand stem cells, okay? This is a single pig, okay? Some pig. So in this pig, they have created myocardial infarction. So with imaging, you can actually see the MI and where there's a perfusion defect. Using CMR, you can actually see where there's a wall motion abnormality as well as delayed enhanced GAD to figure out where the scar is. You can then use another form of imaging, NOGA catheters, potential imaging, to essentially guide where you are injecting stem cells into this pig heart in the peri-infarct area. You can label these stem cells with a PET tracer to tell, yep, they're in there. That's where they are, right there in the infarct area. There's the infarct area. Yep, they're there. You can then use PET to follow this over time to see how long the stem cells are in there. And then they leave. They're gone by 20 hours. Oh crap, where did they go? Well, these stem cells are also fluorescently labeled, so you can essentially take the pig and chop it up and look to see where the fluorescent, I guess this is Texas, you call this barbecue, but you take a look and see where the stem cells are, and here they are. They're all sitting in the liver and the spleen. They've all emigrated out. So that's a great example, and there's lots of different examples of using stem cells to tell what the cells are doing, where the cells are being injected, how long they're living, and then, of course, what they are doing in terms of biologic effect. I'm going to finish up. This is my last slide to show you that imaging. I started off with the slide from NASA showing you that imaging really gives you important, unique information that can be used. This is perhaps the most important slide of using imaging for a very important concept. So this is a slide using fMRI to see whether or not, this is essentially doing fMRI in the gustatory centers of the brain, to see whether or not people really can truly tell the difference between a $5 bottle of wine and a $45 bottle of wine, or for better kind of better resolution here, a $10 versus a $90 bottle of wine. And sure enough, you can actually tell using fMRI imaging that you can actually tell that somebody can tell the difference between a cheap bottle of wine and an expensive bottle of wine. I see Miguel has just entered in the back. Miguel and I have had, many years back, actually had better ways of doing this than fMRI. But just a good example showing you, yeah, molecular imaging and imaging in general can really give you some unique information that can be used in terms of diagnosing disease, but also evaluating therapy. So again, thank you so much for the opportunity to come and visit.
Thank you, Jonathan. That was a tour de force through a very exciting area. So we have a few minutes for some questions. We're going to use the mics. John, good.
That was a marvelous talk. Thank you. You talked a lot about endothelial targeting, vascular targeting. And you seem to have had great success in imaging in that manner. The delivery of therapeutics with targeted nanoparticles, for example, targeting VCAM or targeting P-selectin, those have not proven to be effective methods for drug delivery. What's the difference between the success of the molecular imaging and the therapeutic arm?
Yeah, I think it's sustenance. It's essentially a sustained effect. So, for example, you can use, for example, microbubbles that are loaded with drugs or nanoparticles that are loaded with drugs, and you can target them to these endothelial cell adhesion molecules, or target them to leukocytes, target them to many different things. The problem is just sustained effect. So I've never quite understood why, if a drug is not horribly toxic, why you wouldn't just give it not in an encapsulated, targeted form if it diffuses out, number one. So the encapsulation of things and the targeting to them really needs to be done with drugs and compounds that are either horribly toxic, that you want to use micro doses, very small doses, and just have them accumulate at only the disease state, or to a disease state where you may need an especially high concentration of the stuff, or really difficult to get them out. And so I think that's part of what the problems are using some of the nanoparticles, which is, like any other drug, you need a sustained effect. The other thing is a side part of that question is, whenever people have tried targeting VCAM or P-selectin or anything in the inflammatory cascade as therapy, it's all failed because inflammation is critical to our survival. Going back teleologically, we all died from inflammation and from trauma, right? So because of that, there's tremendous redundancy in inflammation, and knocking out one little limb of it, and we know this from mouse models and all kinds of other models, knocking out one limb of inflammation or one molecule is never sufficient.
Good morning. Thank you so
much.
Good morning. After an acute MI, what causes the whole vasculature to suffer inflammation and increase the risk for in this event?
I'm glad you asked that, because that's actually the topic of my R01 renewal. So it's a superb question, because we have defined. So there's parallel thinking. So 2 years ago, Matthias Nerendorf and Peter Libby and that group defined one mechanism, which is MI mobilizes monocytes from the bone marrow and from the spleen to be released into the microcirculation, and they're especially pro-inflammatory monocytes, and they get their way into plaque. They didn't know how they got into plaque, they just know they got released into the bloodstream. So our data complements that, showing you that there is a diffuse upregulation of inflammatory cell adhesion molecules and platelets. What we don't know is why. And so we're starting to study that right now. We do know that we can knock it down pretty well with potent antioxidants. So because of that, we know that there is some reactive oxygen species that's playing a role in this, but we're trying to track down all of the mediators. One of the things that this is kind of getting ahead of myself, but one of the things we've actually found is when you have an MI, there's a tremendous release of myocyte microvesicles and exosomes. And that makes sense. And they actually are chock full of reactive oxygen species and all kinds of other things. So, yeah.
Thank you for that wonderful talk. I work with John and his guidance on, I'm interested in the concept of cell transitions. When you look at molecular imaging, are you able to image and substitute this for lineage tracing in the context of, like, you track the stem cells? Are you able to substitute this for lineage tracing? And I see that you have some data there.
Yeah, there you go. So yes, you are. So this is just one example of many that do this, which is essentially this is an experiment where they injected in a pro-angiogenic stem cell. So this is a mesenchymal stem cell that they believe has an endothelial fate. And so what they've done is they've essentially labeled a stem, for those of you who don't do optical imaging, I'll be very blunt about this, which is red means you are a stem cell, and if you glow green, it means that you actually are smelling like an endothelial cell, okay? So it's a Tie 2 reporter. So you inject these cells into a mouse that's had an MI, and this is the red range showing you the fluorescence, showing you that the stem cells are still sitting in the heart all the way out to about 50 days. But here's the endothelial marker, and you see nothing early, and it doesn't pop out until about a week to 2 weeks later. So that's a great example of saying, okay, my stem cells are here, I can see them because I see the red, and then I look at the green range and I say, they're starting to become more kind of endothelial-like. The more important thing, I think, is actually, the thing that I didn't go into here is we're actually starting to use molecular imaging to understand the paracrine effects of stem cells, where a stem cell, a lot of people now believe the stem cells aren't building anything. They're essentially the architects. They're full of all these growth factors and cytokines. And so people are starting to, including us, starting to use molecular imaging to understand the paracrine effects of stem cells, what they're doing to native cells such as pro-angiogenic monocytes that are being recruited to the area.
All right, Jonathan, I think we're at time, so thank you very much for an excellent presentation.